Hi, Nursing Diagnosis Management 2, Dr. Kim Paxton. We're going to talk about anemias and leukemia today. Just a brief reminder of your components of your blood and how much is in each section, in case you forgot from your patho class. What's behind that? Well, we could order a CBC because I want to make sure that nobody has developed something new when they come for their yearly physical. I could order a CBC if a person has signs and symptoms of something that I think I'll be able to detect and to determine that differential diagnosis and nail it down to a lead diagnosis. I can order that CBC if I need to monitor somebody who is on a medication of some sort, or if they've been diagnosed with a disease process and I need to monitor that disease process. So there's a lot of different reasons why I could order one. So what does it all mean? Well, first of all, your WBC, as you guys are well aware, is the total number of white cells in your blood. The differential part of that is actually looking at the different types of white cells that encompass it in its totality. Your neutrophils, your lymphs, your monos, your eosinophils, and your basophils. With your RBCs, it's your total reds. Your hemoglobin is the oxygen carrying capability or protein of your blood. The hematocrit is actually the volume of blood that a person has and the red cells of it. And the retic count is actually the percentage of young red cells that have been released into the blood from the bone marrow. And we don't want to see a lot of those because that means that something is occurring within that bone marrow that is abnormal. We have our red cell indices, and this is what we're going to be using to really work with our anemias. These indices help me understand what that red cell looks like. So your MCV is your mean corpuscular volume, and it's the actual size of a red cell. Your MCH, mean corpuscular hemoglobin, this is a calc of how much hemoglobin or that protein of heme that is actually inside each of the red cells. Your MCHC, which is your mean corpuscular concentration, hemoglobin concentration. It's an average of the amount of the concentration of hemoglobin in a cell. And RDW is the red cell distribution, or what is the size of your red cell. Platelets, as you guys are aware, are what help to have our bodies have natural clotting properties, so we need to have those platelets. Sometimes if we have a person that has a platelet issue or they're on a specific medication, we may see that the lab reports on what is an MPV, so it's the platelet volume, or a PDW, which is the distribution width. And just giving you guys a reminder of what all this means. So what does it mean if I have a white cell elevation? Well, it can mean a number of things. So examples of low counts are to your left and high counts are to your right. That low count, we start looking at, does this person potentially have some type of bone marrow suppression? Could they have a virus occurring? Is it an immune problem? Do they have sepsis? On the right, is it a leukocytosis? Again, could it be bacterial or viral? Could it be a leukemia? Is this related to an allergy? Do they have massive tissue death occurring, or have they engaged in a strenuous exercise or under severe emotional stress? So there's a lot that can go into it. Here's where we have to really understand how do we use our chief complaint, HPI, and our ROS to really nail down what is it that could potentially be occurring. For your RBC evaluation, we either have too much or too little again. If we have too much, then we have like a polycythemia occurring. What could cause that? Well, there's a lot of things that can cause it. One of the most common things is actually dehydration. We live here at an altitude, and because we do live at altitude, we can have our patients have higher hemoglobin hematocrits and RBC counts. On your left, we have what causes things to be low. Well, this is where your anemias come into play, and we have a lot of different types of anemias. We also have the component of nutrition that comes into play, chronic kidney disease, and also inflammatory process, which can affect our RBCs. And the platelets, we have the same process occur. A lot of things can affect our platelets, and one of the most important things that can affect them are different types of infections that we can get. And if a person becomes septic, we all know that they can go into DIC. Leukemia and lymphoma, myelodysplasias can occur, chemotherapy, radiation. Medications are a big one that can affect platelets, and I want you guys to think of your NSAIDs for this one. We can have our anemias that will affect them too, your inflammatory processes. So we have a lot of processes in our body that can actually affect and cause problems. I really like this table because it helped me understand, okay, if I'm seeing a change in my WBCs, what could it potentially be leading to? So it helps you understand if you have an increase or a decrease, what you need to be looking for, an infection or leukemia for your white cells, and so on and so forth. It's just a real quick little guide to help you guys get a snapshot picture of what things could be. So what is anemia? Well, you guys are well aware that anemia is a decreased production, abnormal, or an increased production of red cells and the components of the red cells. Now we have a couple different types. We've got our microcytic, we've got our normocytic, and we have our macrocytic. And all of these are related to the MCV. The hypochromic has to do with the color, so the amount of hemoglobin that would be inside, or the concentration of hemoglobin inside the cell. So we're looking at anemias and we're trying to come up with a differential diagnosis. We look at that MCV, or mean corpuscular volume, and we have to look at where is it at. If it's under 80, it's microcytic. 80 to 100, so it actually should be 70, less than 80, so 79. 80 to 100 is normocytic, and 95, greater than 95, but not greater than 100 is macrocytic. So what are things that those would indicate? So your top line is telling you that. Going underneath that, your colors are then going to be your choices. So your macrocytic is your red. So that means we don't have, our volume is less, our actual mean corpuscular volume is down. What could cause that? First thing we're going to look at is looking at our iron stores. And so we'll run our iron assays. If we come back and they're definitely demonstrating that we have an iron deficiency through our values, we'll treat the patient for iron deficiency anemia. If it's not, then we need to check an EPO and possibly do a hemoglobin electrophoresis. If the person comes back normochromic, we need to take a look at what is their hemoglobin or hematocrit. What is their RDW? Are any other types of indices or any other types of cells, white cells or platelets, low? And then move on down. So if we checked a retic count. If the retic count is low, the first column tells you what to do. If it's normal, we're going to go after that erythropoietin and we're going to check that hemoglobin electrophoresis and actually see what these are looking like. And if it's high, what do we need to do next? For a macrocytic, you want to be looking at your folic acids, and here's where we're going to start seeing that pernicious anemia or the folic acid anemia is occurring. And then you'd follow this particular trajectory. So this gives you a really nice depiction of how do you clinically reason through what type of anemia your patient has and what type of tests should you run. This is a great slide to help you, and I will be pulling information from this for your exam. So the basic approach to diagnosing and treating anemia, one, is by listening to your patient and getting that CBC. We have a lot of different types of anemias, and depending upon what that MCV is, will then lead us down the type of track that we need to go to investigate what type we're dealing with. So with our iron deficiency anemias, we can have a lot of different causes. We can have dietary, we could have our small bowel. Now, people who have had gastric bypass surgery are more at risk for having anemias. People who have undergone a hemorrhage of any sort. And the epidemiology of it is that at least 4 to 8% of the premenopausal women have iron deficiency anemia, and postmenopausal women in the absence of bleeding can also have iron deficiency anemia. So the symptoms A lot of times people are going to come in complaining of fatigue. That's the number one symptom people come in complaining of. The other symptom they could come in with is that they have leg cramps. In a child, we could have a mother coming in saying, my child isn't growing as tall as they should be. They're under what they should be. And this is a really interesting one, is that 50% have what's called pagophagia, which is craving of ice or cold or crunchy things. They want to have a crunch. So they could come in saying that they're eating ice. In your physical exam, you could see that they have pallor in their mucous membranes, some ridging, glossitis, enlargement of their tongue, esophageal webbing occurring. When you do their abdominal assessment, you could palpate out a splenomegaly. They could have signs of hypovolemia if they've had an acute loss. And a lot of times if they're anemic, they're going to be tachycardic and tachypnic because we have to increase the respiratory rate and increase the heart rate in order to oxygenate the body. So the workup you're going to do is a really good and strong HPI, ROS, and physical examination. Your labs, get the CBC first. You need this first. If this comes back abnormal, then you can order the rest of these tests. Remember that some insurance companies will not cover the iron studies if you don't demonstrate prior to that the person actually is anemic. You want to evaluate them for hemoglobinuria, so go ahead and get a urine specimen. Look for hemolysis. Everybody needs to have a stool guaiac. And even though your person is 22 years of age and complaining of fatigue, and they're pretty darn sure that they're anemic, you still have to do a stool guaiac. The reason behind that is there is no age determination for the development of colon cancer. Yes, it's more prevalent when an individual gets older, but just because they're 22 doesn't mean that they're not going to actually have that occur. So how do we treat it? Well, typically we're going to use some oral iron supplements. We typically use the ferrous iron sulfate, 325 TID. It is going to take about 3 months for the hemoglobin and hematocrit to begin to rise, so you want to see them back in about 3 months for a lab check. You want to bring them back in about a month though, just to check to see how they're feeling and making sure that nothing else is occurring. Talk to them about iron-rich containing foods in their diets. If you believe this person needs a parental therapy on that, you would only give it if in certain circumstances, and then I would probably encourage you to consult with a hematologist prior to doing it. Etiologies, there's a lot of factors that can come into play for the development of iron deficiency anemia. Here I have got quite a few listings, but look at your top 3. Abnormal uterine bleeding, long-term use of aspirin or nonsteroidals, and a type of colon cancer. Those are your top ones, and these are your do not miss ones. I thought this chart was really good because it helps you understand what you would see in your iron studies, and from those iron studies, what is the actual differential diagnosis that would be your lead. So I thought this slide would be very helpful to you to help explain that. With megaloblastic anemia, this is about the synthesis and the division of cells. We typically see this with our folate deficiencies, our vitamin B12 deficiencies. Medications can cause this, and HIV infections actually is one of the mediating factors of this type of anemia. So for this type of anemia, our vitamin B12 deficiency, here's where we primarily get our vitamin B12 throughout our day. So it's basically coming through our diets. For pernicious anemia, this is the failure of the intrinsic factor secretion due to autoimmune destruction of the parietal cells. So we're not getting the parietal cells secreting like they're supposed to. Therefore, we have malabsorption occurring. H2 antagonists can actually inhibit the secretion of IF. And if that happens, this person can then become predisposed. Also think about patients that are on PPIs, because that same inhibitionary effect can cause this too. Some other types of things that can cause megaloblastic anemia can be pancreatic insufficiency, IBD, ileal resection, your patients who have undergone gastric bypass, Healing infections, and any type of chemotherapy drug can actually cause problems. So how would they present? Well, they're going to present with a macrocytic anemia, so their MCV is going to be large. One of the cardinal signs that people present with is a hyperpigmentation of the skin, but also an inflammation of the tongue or enlargement of the tongue. With the B12 deficiency, you could have patients complaining of paresthesias to their upper or lower extremities because we need that B12 to maintain the integrity of the myelin sheath. And that can get destroyed or impaired if we have a B12 deficiency. The history, looking at the diet, looking to see what kind of surgeries they've had, any autoimmune disorders, are they HIV positive, what is their lifestyle, are they a chronic alcoholic? Gaining that history will get you a better understanding of could this person potentially have the megaloblastic anemia. Moving forward, the workup you're going to do with them, you're going to start with that CBC and then move on to your iron studies, a peripheral smear, a retic count. You can order vitamin B12. The Schilling tests are not being done as they were previously. We're literally going to a serum cobalamin assay and actually learning what that is. We can do a serum folate if we believe that this person has a folate deficiency. We can do a serum homocysteine or cysteine rather also. And again, we could always send them to a hematology for a bone marrow aspiration or biopsy if our diagnostics are coming up back inconclusive. So for the treatment, if it's a B12 deficiency, we're going to administer to them parenterally between 100 and 1,000 micrograms daily for the next 2 weeks. And we can also give it orally if we need to. Sometimes the patient may require the parenteral administration on a monthly basis for the rest of their lives. It just depends upon what the underlying cause is. If the folate acid deficiency, we can give 3 to 5 milligrams a day. If we really don't know, we're going to give both of them. We need to make sure that we are monitoring their potassiums carefully when we start giving these because there can be shifts that will occur between the sodium and potassium inside of the cells. So we want to make sure that we're assessing their potassiums. When you start the treatment, checking that potassium at that 2-week level and then monthly until they stabilize out is appropriate. Aplastic anemia is actually a fairly rare anemia to have. It's actually a failure of the bone marrow. And with this, you can get a peripheral pancytopenia, which we're going to talk about in just a little bit. What happens is that with aplastic anemia, the bone marrow begins to cease production of both RBCs and WBCs. A lot of times, this is actually caused by an autoimmune problem. Drugs can cause it, radiation, and different types of infections can also cause it. So how does a person look when they come in with pancytopenia? And what pancytopenia is that all of your WBC values, RBC values, platelets are actually low. So you want to do that CBC, and then you're going to get it back, and it's going to be like, whoa, we got a problem. Order that peripheral smear. You can order other types of biochemical profiles, such as your CMPs, to look at what could be causing this. You can look to check to see if this person possibly has pituitary disorders or TSH problems. You might want to do an infectious disease profile on them. And with this type of patient, we're going to be transferring them actually to hematology once we have their workup complete and getting them situated in there. The abnormal production, these are your hereditary hemoglobinopathies, so your thalassemia and your cell anemias. I can hardly say this word, thalassemias, these are actually genetic disorders, and this type of blood disorder actually occurs with a mutation that occurs in the globulin gene, which decreases the production of globulins. And we have alpha globulin and we've got beta globulin. And then depending upon which one is affected and how many genes are affected will then determine which type of thalassemia a person actually has. Sometimes we can actually get lysis of the red cells, which will then further produce a more significant anemic effect. The treatment for thalassemia is dependent upon what type of thalassemia that we have. On the bottom of this particular picture, it'll tell you what your treatments would be. We are going to be referring these patients actually to a hematologist. A lot of times these patients are diagnosed in their pediatric or even in their infancy because they have failure to thrive. They come in with tachypnea. The parents say they're breathing fast, they're pale, and they typically are seen early in life and treatment started early in life. Just another depiction of what the thalassemia looks like. This is actually a depiction of the alphas on the left and the betas on the right. So here we have a genetic component missing of the beta, and then we have the second gene. So there's two alphas and two betas. The more genes that you have affected, the more significant is the thalassemia. With sickle cell, this is also a genetic disorder, and it produces a vaso-occlusive crisis because the sickle cells cannot move properly through the vasculature, and they wind up rupturing, and which then predisposes them to platelets adhering and other red cells adhering, and small clots begin to develop in small vessels. Patients will experience the pain, and what the pain is the actual hypoxia from the vessels being occluded that are leading into the tissue areas. With patients that have sickle cell, we want to do that baseline CBC. Typically, if this person does have sickle cell, their hemoglobins typically come back low along with their hemoglobin and hematocrits being low. Their platelets will be elevated. We can do a peripheral smear on these individuals, and we will find out that they do indeed have sickle cells appearing. One of the other main things that we see are called Howell-Jolly bodies. I want you guys to kind of remember that that goes along with sickle cell. So if you see Howell-Jolly bodies, make it the association that this person probably has sickle cell disease. So how do we actually manage this? Well, we need to go ahead and work with the vaso-occlusive crisis. And we need to be supportive. Hydrea is one of the products we can give. We can do transfusions. We can definitely work for pain management on these individuals. We do fluids on these individuals. We need to be monitoring them so that they don't develop pulmonary hypertension for them. A lot of times they wind up in the emergency rooms for their care, and that's more related to the chronic pain crises that are occurring. Moving forward a little bit, we've got hemolytic anemias, and these are the ones where there's actually a lysosing occurring of the red cells. And then we've got our intrinsic red cell deficiencies and our extracellular ones. Your sickle cell syndromes, which is the lysing of your red cell because of the sickling, that's more of an intrinsic. We don't see a lot of these. A lot of these are ethnically or culturally mediated. So depending upon that, you may need to evaluate a little bit more intensely on them. Our chronic inflammatory processes like Crohn's disease, ulcerative colitis, rheumatoid arthritis, sarcoidosis, things like that, these can also cause issues. You can also have drug chemical mediated processes with medications, and then our post-infectious processes when people have had sepsis can cause problems too. So with our hemolytic anemias, we want to make sure that we're doing that CBC, order that peripheral smear, be looking for abnormal cell structures to be showing up that are found by the med techs. We can occasionally see an LDH elevation, but it's not necessarily specific to hemolytic anemias. We can have a low hepatoglobin, which suggests hemolysis is actually occurring. We usually see an indirect bili being elevated secondary to the lysis that's occurring. For the people who have these type of hemolytic anemias, depending upon what type of hemolytic anemia it is, it either will be able to be managed in a primary care setting, or depending upon what is the mediating factor, it may actually be needed to be referred over to hematology for management. Polycythemia. Polycythemia is too many red cells, and this again can be a primary problem where it's actually a genetic mutation, or it could be secondary related to some circulating factor. Most of the time, the secondary ones are related to the erythropoietin and the erythropoietin's response to hypoxia. People who smoke are continually dehydrated, taking exogenous testosterone, not endogenous, can actually sometimes have this happen. People who have sleep apnea, you will find that they have an increase in their RBCs. Too, you see that quite a bit actually. So you won't just see the RBC, but you'll also see the hemoglobin and hematocrit increase. You have to look to correct the underlying problem to correct the polycythemia. For platelets, we began talking about this a little bit. I'm going to move us forward to the different types of platelet disorders. These are the 4 top ones. I am not going to go into any great depth and go into explanation of these. You've already been exposed to the hemolytic uremic syndrome. We had that come forward with our renal patient last week. But I wanted just to bring them forward to you. You can definitely look them up in your text, but I'm not going to go over in any great depth with you these right now. Going back into our WBCs now, we're going to start looking more at those leukemias. So bringing back our initial slides. So what is leukemia? So we have 2 different types of leukemia. We have an acute leukemia and we've got a chronic leukemia. Our acute leukemia is something that we typically see as an overgrowth of immature blood cells or blasts. So when we do our CBC, the MedTech may report immature white cells showing up in part of the smear. This acute leukemia is actually life-threatening because there's not enough mature cells to prevent anemia, so the red cells as well as the white, and this predisposes the person to infections. Chronic leukemia is actually a slow overgrowth of mature cells. It's not life-threatening to begin with, but we do need to be aware that it can cause problems with anemia, bleeding, and infections as well. This particular slide helps you understand when you're looking at your WBC and you're seeing an elevation, what do you do next? Well, after you first identify that you have an elevation or you've got a leukocytosis, now you have to look at the white cell indices, which are your monocytes, EOs, neutrophils, lymphocytes, and basophils. So you have to look at those next. If you have a peripheral smear, you want to look at that peripheral smear and see, do you have immature cells being reported on that? Is there anemia present along with this? What are your platelets looking like? Moving on down and keeping with those white cell indices, do you have an increased number or normal appearing neutrophils? What are your actual eosinophils looking like? Now, if the person has an elevated WBC and they have EOs, make sure that you evaluate out if this person has allergies or not, especially seasonal allergies, because they can have an increased eosinophil count and it may not necessarily be related to a leukemic state. So as you're looking at this, follow your chart on down. So if we have increased neutrophils, looking for those blast cells. So how increased are our basos or our EOs? Do we have a myelogenous leukemia occurring? To confirm this, we're going to need to do a bone marrow aspiration. If you get a patient that you have a WBC that's in the 30s or the 40,000s, and you're not able to attribute it to the person having an infectious process, you're not able to link it to the patient having high dose prednisone, and that's where it's coming from, we have to be looking at the potential of this person having a leukemic state. So you have to go back and look at what is the person's history of present illness, what does their ROS look like. And a lot of times what you're going to find is that people with leukemia are actually presenting with signs and symptoms of low-grade possible viral infections or low-grade bacterial infections. But one of the constant determinants that they present with is this fatigue. They are constantly fatigued. Now, acute myeloid leukemia is another type of our leukemia. It is considered the most common type of acute leukemia. It typically is one of the leukemias that we see in the adults, not so much in children. And again, leukemia can present as fatigue as the overarching piece. And we all know we're going to do that CBC first. But other things that you could see when you're seeing somebody with that complaint is they may say they bruise more easily or they're bleeding longer. They could have low-grade fevers. They could have a sinus infection that doesn't seem to go away. When you do their CBC, you can see pancytopenia with the red cells, the platelets, and the white cells. Only about 10% of the AMLs actually present with a leukocytosis or cells that are over, white cells over 100,000. One of the interesting pieces that you'll find is that on that peripheral smear, IR rods are actually going to be present, and these are immature myoblasts that will actually come present in the smear. If your patient presents like this and you're seeing this, this is a medical emergency. You would send them to an emergency room, but you would also get on the phone and contact an oncologist or an oncology hem-onc doc, have a conversation with them so that they could be followed up actually once they hit the ER by that physician calling into. I've actually encountered in my entire practice time about 4 patients that actually presented into my internal medicine practice with the only complaint of fatigue, and they wound up having AML. So just looking at a actual person's lab values, we're looking at the hemoglobin being 7, and we've got that platelet count of 8, but look at how they changed over time. And then coming down here and looking at the pre-myelocytes and their blasts and their blast absolutes, here's where we're actually seeing somebody that is acute myeloid leukemia, and instead of the chronic. But again, now they've started into treatment, so they're progressing. But you can see we started here in March, and then we're moving forward here into April, and how they've progressed. So here they were fine. They looked great here at the beginning of March, but as the disease progressed, they progressed actually into the actual myeloid leukemia. Interesting is that in June 29th, they had a blast percent of 24, and a couple of things were being shown. They were being monitored, but then they fulminated completely. And this is from not my particular practice, but somebody else's practice, and they just shared it with me. So acute lymphoblastic leukemia, or ALL, this is the leukemia that is most common in children. So 80% of children, if they're going to have a leukemia, will have this one. And again, the presenting symptom is fatigue. The mother will bring the child in saying the child is tired all the time. They're getting constant infections. They're losing weight. And then you run the CBCs and you start seeing changes in abnormalities. This is a child that's going to be referred to hem-onc as well. Chronic myeloid leukemia. This one here is very rare in children, but only 20% of adults actually present with this. Again, you're going to be looking for those myeloid cells in the leukemia, leukocytosis. These patients will also complain of fatigue as one of their main symptoms. And again, this is going to be somebody, if you're not sure what you're seeing, it isn't required of you to diagnose the type of leukemia. It's helpful to the hem-onc doc if you can give them some kind of an understanding, but understanding that you're seeing abnormalities that warrant that referral is what's most important. Chronic lymphocytic leukemia. This particular leukemia we see more in our Western hemisphere, in the Western hemispheres than we do in the Eastern hemispheres. This one here is one where we have the white cells, and we have the presenting component that helps us understand what we're dealing with is the elevated absolute lymphocyte. And that elevated lymphocyte is keying us in that we could have a problem. We're going to find some lymphedema. We'll have hepatosplenomegaly. And the cardinal thing is we're looking for those smudge cells. And those smudge cells are cardinal for chronic lymphocytic leukemia. Myelodysplastic syndrome. Um, this is not a common type of occurrence that we see, but for this particular type of syndrome, we could start seeing changes that are occurring with our cell structures, and we start seeing cytopenias or different cells that are showing less than normal. And that's telling us that something is occurring within the bone marrow. We need to be monitoring that and watching that patient very carefully. People who have chronic diseases are more at risk for this type of syndrome to occur than healthy people are because of the medications that we actually use. This is actually considered a pre-leukemic state, especially if we are seeing white cells being affected. Interesting is that 1/3 of patients who start with MDS actually progress into acute myelocytic leukemia within 3 years, which is very interesting. Going back to the pancytopenia, where we have so many cells that we don't have enough of, this little table helps you understand or give you a better depiction of what am I looking at? What should I be investigating for? And then any abnormal CBC, if you're not able to explain or identify comorbid conditions to go with it, and you're trying to correct it and it's not, you're doing nutritional modifications, they're not working, or the threshold continues to be low after all interventions, don't hesitate. Refer them to a hematologist or a hemonc. You will not go wrong. I appreciate you listening to the lecture today. I hope you guys have a great week. If you have questions, don't hesitate. Make sure you contact me.